Okay, good morning, good afternoon, good evening, depending on where you're joining us today. I hope everybody is doing well in this unusual time around the world. Welcome to the MechE Alliance seminar series. Again, my name is Brian Anthony, your host for today, along with Teresa Worth. It's my great pleasure to introduce Alex Benjamin. He's a doctoral candidate in mechanical engineering and computational science and engineering, doing some phenomenal work in improving the capabilities of ultrasound imaging, with a particular focus in looking at liver diseases, and fusing together both his knowledge of mechanical engineering and tissue properties and computer science to really potentially revolutionize the way that ultrasound is used. We'll hold questions until the very end. Please ask them through the Q&A. I will marshal those questions towards Alex at the very end. And as I think everybody was alerted as you came in, this is being recorded and will be made available after in about a week. So with that, Alex, look forward to hearing your talk on 3D organ property mapping using freehand ultrasound scans. And thank you for your time and take it away.
Excellent. Thank you, Brian. Good afternoon, everyone. Thank you for joining. I think my mom's also on this call. My mom always asks me what I do for a living. I think it's great. Now she'll know. But I'm broadly going to be talking about using the use of ultrasound for three-dimensional mapping of organ properties. And before I jump into the technicals, I just want to give a little bit of background on why it's necessary and what the motivation is. So conventionally,
Alex, are you, I'm gonna turn my mic off in a second, sorry. Are you able to go full screen, Alex?
I wouldn't be able to click. The animations will work fine. It's just that I need this.
This is what we're doing.
Yeah,
okay,
the sidebar.
Perfect.
Yeah.
Okay, great, thank you.
So quick motivation on why we need three-dimensional property maps. So conventionally, ultrasound has been a 2D imaging modality. When you tend to get ultrasound images, they tend to be images that are 2D images that are largely qualitative. Oftentimes what happens is that disease pathologies tend to be non-uniform and heterogeneous. Classic example is breast cancer. In the adipose tissue, generally, you have a non-uniform and non-homogeneous distribution of density. And oftentimes the density, and it has been shown that the density of the tissue correlates with the presence of malignant lesions, for example. And so it doesn't suffice just to capture a single viewpoint of the breast tissue, and you start to require a full 3D map of the underlying property to be able to stage the disease and also to be able to compare over time. Another example, and this is specific to what I've been working on, is non-alcoholic fatty liver disease. As its name implies, it's basically fat infiltration in the liver. But what happens is in the early stages, you have this diffuse infiltration of fat, and generally speaking, it's homogeneous. But as the disease progresses, you get localized regions of scarring and fibrosis. And if you do not have a full 3D picture of the organ, you tend to miss these regions when diagnosing. So currently, the way it's done is CT imaging and MR imaging are the state of the art, because they can produce volumes and they can produce accurate volumes. The issue is, however, that it's not a point of care application. It takes time, it's costly. In the case of CT, you have exposure to ionizing radiation, and it doesn't lend itself really to longitudinal monitoring, because you want to do this diagnostic screening frequently and you want to do it in a cost-effective fashion. So the current need that I was trying to address was, how do you develop a low-cost, portable method of generating three-dimensional organ property maps? There's two problems, generally speaking. One is the acquisition of three-dimensional volumes, and the other is actually coupling these three-dimensional volumes with property maps. So the first thing I'm going to broadly speak about is, how do you get 3D volumes from two-dimensional ultrasound images? So the obvious answer is, of course, with the recent advent of technology, there are probes that are capable of producing 3D volumes, but those are expensive at the moment and they're not widely available. So how do you put to use existing commercial ultrasound scanners? such that you can extract 3D volumes. And the framework that I've been working on for the last 4 or 5 years, roughly speaking, would look like this. This is the grand vision of what would happen. You have a patient, and in this case, the patient's liver is of interest. You have an ultrasound probe, which is to the right of the screen, which is equipped, retrofitted with a set of low-cost sensors. And these sensors are cameras, inertial measurement units, and also cameras that don't function in color space. They function in the infrared space. And through a combination of these sensors, you are able to, as the clinician scans the body or the organ of interest, localize the probe in free space. Basically, that means you know where the probe is, how it's oriented, and you have all the necessary information. So now what you can start to tease out and what you can actually do is, rather than relying on two-dimensional images, you can take the two-dimensional images and you can take the two-dimensional property maps you acquire and that you would otherwise use your mental picture to contextualize, and you can just combine it with the position and orientation information, and you can actually get a full three-dimensional map of the organ and the volume. And so this allows you to compare the organ as a whole at time point 1 and then any subsequent time point. So the utility of 3D volumes becomes very clear on this slide, because if this were a fictitious property map, you can see that it's definitely not uniformly distributed. And depending on where you acquire the image, you're making a very different diagnosis. So I'm going to jump into some of the results that we got where we attempted to localize this probe in free space and create volumes. For now, I'm going to focus on just the structural volume itself. So what we were able to do is we were able to retrofit a existing commercial probe with 3 specific sensors. In this case, they were infrared cameras, regular cameras, and an inertial measurement unit. And for those who are familiar with this method, it's generally called SLAM, which is simultaneous localization and mapping. Basically, it means as the probe is scanning the patient, these sensors are determining the position and orientation of the probe. And what we did was we initially tested it on an ex vivo sample, which was a sheep kidney, which we embedded in a block of gelatin, which is what the figure on the leftmost is the kidney, the middle is it embedded in gelatin, and the rightmost figure shows the fact that we allowed variable scanning configurations, because in the clinical setting, clinicians do whatever they need to do to get the right vantage point, to get the right image. So we allowed for 4 different scanning configurations, the details of which are not important, but basically we allowed for variable scanning modalities. And so what we were able to do then is we were able to compare the volumes we acquired with what is used currently in a clinical setting. And in a clinical setting right now, you use CT, which is an image on the right. And if you do tend to use ultrasound, clinicians default to a method called the ellipsoidal method, which from its name implies that they assume it's an ellipsoid and they estimate the volume based on gross measurements. And we recently published a paper. And so on the left, what you're seeing is a ultrasound image of the kidney, a segmented image, which shows the white pixels show the kidney and the black is the background. And the rightmost image shows completed volume reconstructions of the kidney. These are in the form of meshes, point clouds being converted to connected manifolds. And to the best of our knowledge, this is the first demonstration of kidneys produced with this level of accuracy. But this is qualitative accuracy. This shows the morphology and it tells you that, okay, you're roughly reconstructing a kidney. What was more important to us was actually comparing it to ground truth. And we were able to compare, so I'll give people a little bit of time to digest this, but in the 3rd column, you have the ultrasound measurement of the volume of the kidney. In the 4th column, you have water displacement, which we consider ground truth. The 5th column is the ellipsoidal method, and the 6th column is CT. And you'll see that the percent error for the ellipsoidal method is fairly large. It's about 13%. It overestimates the volume of the kidney for obvious reasons. The ultrasound method and the CT method, I cannot make a claim that ultrasound is better than CT, but the errors were comparable. And what this led us to believe is that freehand ultrasound scans can potentially serve as a surrogate for volume estimation in people. And that was a highlight and a result that we found. For people who are familiar with SLAM or people who are not familiar with SLAM, there is, before I get into this section, there's an obvious problem with the way this was laid out, in that if the ultrasound probe is being localized in free space and the patient moves for whatever reason, your tracking is thrown off. Your estimate of where you are in space is incorrect. I'll get to that in a few slides, but I just wanted to point that out as an obvious drawback. But one of the things we could do, and this is actually my favorite slide, was because we can scan a patient multiple times and get volumes now rather than just images, we can ask this question of, if I have n different scans of the patient, how do I combine these n scans to get the best estimate? So as a dummy example, what I did was I performed n scans of a spine phantom. And what you're looking at is the last 4 or 5 sections of the lower lumbar region. And the color scheme on this slide basically shows you that there are certain points that are reconstructed in space that are of poor quality, which are high uncertainty. And then there are certain points which are green that are low uncertainty. You're more confident of those reconstructions of these 2 sets of points. But because you have the full volumes every time you do these scans, you can combine an arbitrary number of scans to get an arbitrary degree of precision on the volume that you're trying to reconstruct. And what you're actually able to get away with is actually something pretty cool, which is this mesh-based reconstruction of the spine, which is a result of, I think it was about 13 or 14 scans that needed to be fused together. People may be thinking that that's a lot of scans to perform, but it really does not take very long to scan 4 vertebrae of your lower back. The whole 14 or 15 passes probably take about 5 minutes. So in 5 minutes, you can get a pretty high level of detail and accuracy from ultrasound scanners, which was previously not possible because you would rely on 2D images. But moving forward to the initial problem that I alluded to is that patient motion is a real problem. Patients move, that's just the way it's going to be. You cannot ask people to be immobile during the entire scan. Breathing, if anything, if there's no voluntary action, there's breathing at the very least. And so if you just hold a probe on a patient and the patient moves, your sensors are confused. They don't understand if it's the probe that moved or the patient that moved, and your reconstruction is error prone. So we came up with this idea over the last couple of years about what if you were not using the environment, you were not taking cues from the environment to localize the probe, but instead you were taking cues from the anatomy of the patient itself. And because our setup had 2 infrared cameras, we began exploring this idea of what if you could actually image the superficial veins. These are veins that are very close to the surface of the skin, and use them as localization landmarks. Much like you would ping off cell towers, you could extract certain features off your veins to do the same thing. So now, instead of the cameras pointing towards the ambient environment, they were pointing towards the skin. And skipping over some details, what we were able to do is we were able to extract, and this is the green dots in the right image, we were able to extract certain salient features of what we call the vasculature network. And these are, these would represent branches or junction points, and these would, and there has been literature to indicate that these are stable over time. So if you image somebody's blood vessel network on day 1 versus day 30, you don't expect it to have dramatic changes. So these can serve as robust localization landmarks. So our proposed fix to the issue of patient motion is, rather than localizing the probe relative to the environment, we'll just localize the probe relative to the patient itself. So if the patient moves, the landmarks move, and the localization algorithm realizes that the probe really did not move. And as a first demonstration, what we were able to produce were actually, we were able to show that during the scanning process, we can actually create 3-dimensional maps of the superficial vasculature and also localize the ultrasound probe relative to these vasculature maps. Now, in the interest of full disclosure, these maps, as they stand now, are fairly noisy. So the localization also tends to have errors. But keep in mind that the sensor that we're using on the probe is, you can buy it for $100. So it's not a very high resolution camera. In the limit of using a high resolution infrared camera, you could resolve and get much, much better localizations. So that's generally, up until this point, it's basically, can we reconstruct volumes of organs, and can we account for one of the major pitfalls in the clinical setting, which is patient motion. Sorry, that's my neighbor. And then part 3 of the talk is, and I was discussing this with Brian, it's great and everything that you can produce volumes, but what people are really after are property maps, because volumes in a clinical setting don't really tell you much. Okay, yeah, your kidney is shaped this way. Okay, your liver is shaped this way. It doesn't tell you much about whether it's diseased or not. So what we were after was, okay, now that we can reconstruct 3D volumes, rather than stitching together images, can we actually stitch together property maps? And for that, we would need to estimate 2D property maps. And in our case, we were focused on sound speed. Quick overview on why that makes sense. Ultrasound propagation in tissue largely relies on the sound speed of the medium. So the faster your sound speed, the faster the waves propagate. But the moment you have a change in sound speed in your medium, that's when you start to get reflections of ultrasound waves. So embedded in these reflection signatures, you actually have a lot of information about the sound speed distribution within the medium. That's what we were trying to essentially tease out. And so the work that I've been doing now, and this is currently in progress, is because, you know, we have the ability to track an ultrasound probe, we can interrogate a domain of interest, and I'm looking at the image on the right, the red blob. We can interrogate that domain of interest from arbitrary viewpoints. And the reason we can do that is because we know where the transducer is at any given time. And by making strategic measurements to regions within the domain or regions that are beyond the domain, we can actually start to formulate an inverse problem which says, I know that sound waves took a certain amount of time to travel to this point, so tell me something about the distribution of the sound speed along that path. Again, if there are questions specific about the inversion problem, I'm happy to talk about them later, but essentially one of the benefits that our framework has is, in the case of a regular probe, if you weren't able to track it, you really suffer from being able to, you really suffer from the fact that the viewpoint is limited. And when you have a limited viewpoint, you have much less information that allows you to reconstruct the underlying sound speed map. But if you're able to scan a wider angle, you start to get more information from more parts of the domain, which better constrains your problem, which allows you to better estimate the sound speed and slowness map. And our initial demonstration that we did was, we basically had the probe, we had the camera on there that was tracking the probe, and we essentially filled up a tub with water and threw in a hot dog in there. And our idea was, you know, can we reconstruct the sound speed within the hot dog and separate that from the background sound speed, which was water. And currently the paper that's in works, and we're hoping to submit this soon, basically showed that instead of looking at it once from a single point of view, which is image number 3 on this slide, if you look at it 7 times from 7 different viewpoints or vantage points, you get a lot more constraints on your inverse problem, which allows you to much better estimate the underlying slowness map. And what we were able to show is actually the reconstruction, which you see on this slide. The left image is the B mode image, is the ultrasound image. And the right block is actually the sound speed reconstruction. So you'll see a couple of things. One, you're able to extract the structure, which is the circular shape of the inclusion, really well. And that would not be possible if you only looked at it from one viewpoint. And the second thing is you're actually able to also extract the sound speed and able to differentiate it from the background, which is distilled water. And in the case of distilled water, we know that the sound speed is 1480. So the hot dog has a much higher sound speed than the background medium. So our hope is that instead of fusing images, which are on the left, to get structural volumes, you can fuse sound speed maps, which are on the right, to get sound speed volumes. And having sound speed volumes from time to time in a clinical setting allows you to consistently compare and also diagnose a variety of diseases. So that's the endeavors that are going on. Of course, there's a lot of work and a lot of obvious next questions, but from the point of view of content, that's all I had to present. And I think I'll leave it to Brian to moderate some of the questions. But if you guys have technical questions, everybody has my contact information in the email, so please feel free to reach out. I love talking about this stuff. But yeah, thank you for tuning in and taking time out of your lunch. I appreciate it. Thank you.
Great, thank you, Alex. I send you the virtual and the physical clap here.
Thank you.
So there was, let me kick off. So please ask your questions in the Q&A. Let me kick it off with one question. You had commented at the very beginning about sort of that 3D probes do exist, and they're complex and expensive, but over time those are going to get less complex and less expensive. How does this mesh? Is there an intersection between using a true 3D probe and the frameworks that you're talking about?
Yeah, so right now the probes produce 2D images and we stitch them together to get 3D volumes. But the probes that Brian mentioned, these probes will inherently produce tiny volumes. They won't be large volumes. You won't be able to capture the entire organ, but you'll get tiny volumes, which you'll have to stitch together to form the whole volume. So the architecture still carries over because you'll be able to localize these sub-volumes, and these sub-volumes can then be stitched together to form a larger volume. There are certain cases where stitching the sub-volume is not as straightforward as just using the position and orientation information. In that case, you might have to rely on features within the volumes themselves to do some form of registration. But the architecture and the framework carries over, even if you had a probe that produced sub-volumes, that produced volumes instead of images. And that's the hope. The hope is rather than stitching images together, you start stitching volumes together. So you get your organ volume much faster. That's the idea.
Thank you. So there's a Q&A here. One of the questions from Mike: can you explain or give an example of how the sound speed maps are helpful in a clinical setting?
Yes. So classic example, so I'm working with fatty liver disease. So one of the papers that we had published earlier was basically, it basically established a correlation between bulk sound speed within tissue as a function of fat infiltration. So if you have 0% fat infiltration, your healthy tissue has a sound speed, for example, 1500 meters per second. Now pure fat on its own has a much lower sound speed, which is 1400. So the more fat infiltration that you get into the liver, and if it's diffuse enough, you get a volumetric reduction in the sound speed. So if you go from 0% fat to 100% fat, your speed would go from 1500 to 1400, and anything in between, you would see a corresponding downshift. That's one example. It's not as simple in an actual liver because fibrosis and cirrhosis tend to increase the sound speed. So, but that's one relevant example where it might be useful.
Great, thank you, Alex. Another question from Vipender. Could you adapt the method to look at internal vasculature like the aorta? Would be useful for looking at plaques, atherosclerosis and plaques.
That's a great question. So there's two ways you can answer, two ways you can look at that. One is you can use the existing localization framework and say, rather than reconstructing kidney volumes, I'm going to reconstruct plaque volumes. It would rely on having good segmentation of the plaque within the blood vessel itself. But yes, you could effectively get estimates of plaque volume as a function of the vessel itself. But the other point, and this is a much harder research problem, is rather than relying on superficial veins to do your localization, can you use deep vasculature, which is much more readily visible in ultrasound images, at least the large ones, to do the localization? So now you truly do a pure SLAM, simultaneous localization and mapping, based on ultrasound images alone. And then you would actually potentially not even need external sensors. But yeah, there's two ways to look at that. You can reconstruct plaque volumes with what we have now, Or you could reconstruct plaque volumes while doing the localization also relative to those blood vessels. Both interesting.
Great, thank you, Alex. Another question from Amukund. Can your technology scan soft tissues embedded between hard tissues? So flipping around the plaque problem. Say for example, cartilage surrounded by hard bones.
Okay, so this is great. I feel there are a couple of people in our lab right now who are working exactly on this, and I feel like they would be able to answer this much better. But I will make a disclaimer. My sound speed estimation technique does not deal with hard surfaces like bones because there is significant ray bending that occurs, and that has to be accounted for. So it would be very difficult to image the bone marrow, for example, because you rarely get transmission through the bone at the frequencies that I'm using. The frequency of the probe is about 5.5 megahertz. You would have to go down to 1 megahertz or below to be able to get transmission through it. But to that being said, there's a lot of work being done by other people in our lab to get sound speed estimates of within the bone geometry. But it requires accounting for the fact that you don't transmit as much and the waves bend dramatically. So you need to adapt your inversion framework to account for that.
Great. Thank you. So Marius asks, well, first says, great talk, Alex. What governs the resolution in your property maps? For instance, if you have heterogeneous materials, what is the feature size that you can resolve?
Yeah, this is a great question. So right now, the resolution of the property map is limited by the two things, the aperture, basically the field of view, how much. So in the limiting case, you would have a domain and your ultrasound probe would go all around the inclusion, and you would get as many ray crossings per pixel in your image domain as you choose. You could keep going around in circles. The reason this problem is so difficult is because your resolution suffers in the horizontal direction because you have very few ray crossings, because you can never in a clinical setting image an inclusion from the side. You are imaging it from a single direction. So I think the predominant limiter to resolution right now is the fact that you don't have enough information, enough rays crossing per pixel within your inversion domain. But if you did get that, then you would be able to significantly increase the resolution, increase what heterogeneous speed distributions you would be able to resolve.
I'm going to ask a related question that's out of order here, but it touches a little bit on the resolution. How are the sound speed maps sensitive to probe frequency? 5 megahertz versus 10 megahertz was the example asked.
How are the sound speed? So theoretically, when it comes to ultrasound images, 10 megahertz is strictly better than 5 megahertz because you're able to resolve smaller features in both dimensions. The problem is attenuation scales to the 4th power with frequency, right? So, and the framework that I have right now relies on having round trip time of flight measurements. So if you go from 5 megahertz to 10 megahertz, yeah, you can resolve smaller features, but you will physically also get less signal from deeper regions within your tissue. So you won't have as much time of flight information from deeper regions within your soft tissue. So your resolution will naturally just degrade. Your sound speed resolution will naturally degrade because you have fewer measurements further into the tissue, which is why this is best done for lower frequency probes because they tend to penetrate and get much further into tissue than high frequency ones.
So maybe a related question here, another one from Robin. Can sound speed maps help to get some functional information of the tissues, for example, presence of cancerous tissues?
Okay, so there's, yes, I mean, provided there's enough clinical evidence to indicate that cancerous tissues tend to differ from regular tissues in either density or bulk modulus, then yes, the sound speed would be able to tell you, because sound speed at the end of the day is a function of those two variables. But if benign tissue and malignant tissue appear the same as a function of those two parameters, then probably not. But yeah, it does have the potential. At the very least, it has the potential of telling you if there are sound speed aberrations within the tissue. for further diagnostics.
Thank you, Alex. So I think maybe one more question here, which is actually I'm going to combine two that were asked by both
Yep.
Holly and an anonymous attendee. So first, thanks, Alex, for presenting the cool technology. The sound speed map from ultrasound sounds more capable than existing imaging modalities like CT. So do you see this system being used for clinical settings soon? What are the next steps to make it widely available? And then the next question I'll just pile on there. As it stands right now, what would be the approximate cost of a fully commercialized handheld probe, assuming you have the ultrasound machinery? So it's, how do we take this out of the lab, the commercial pathway to get it out into the world?
So a couple of things. It's not more capable than CT. If I said that, I'm not correct, because CT has a much higher resolution. X-rays have a much higher resolution than ultrasound ever will. My point is that they were comparable, that it could possibly be comparable in error of volume estimation. And if that is true, and for example, 5%, if you're able to live with 5% error, then yes, you would much rather use ultrasound because it's faster, it's cheaper, it's deployable, portable, all that good stuff. And then I guess the next two questions are, what are the next steps and how much would be the approximate cost? Why, yeah, those are, so what are the next steps? I think the next steps would be to demonstrate this, of course, in volunteers. I mean, have some notion of how well it performs with actual patients. That would be, I mean, and in terms of the cost, if we're talking about retrofitting existing probes with low cost sensors, the cost is fairly low because the sensors are cheaper. But if we're talking about developing a probe itself that has all the necessary sensors embedded in it, so it's essentially like a smart probe, then yeah, I guess I'll point to Brian. Like I'm not sure, I wouldn't be able to put a number on it. But there are two very different scales of cost is what I'm trying to get at. If you're trying to use existing architecture by exploiting your sensors, that's much lower cost and risk than it is to develop a probe that has all the sensors you want embedded in it. Both have their pros and cons, but yeah, it's hard to actually put a number to this.
No, Alex, thank you for that. And commercialization. I guess maybe the other thing that I would add as the corollary to the statement. I mean, you have been doing human studies, not under the COVID era, but maybe you can just mention some of the human studies that you have done, and what that's looked like in the clinical setting, and then we'll close it out today.
Yeah, some of the preliminary liver and kidney work was done on volunteers. We were able to actually scan volunteers. The good thing is that with the existing framework, the scans themselves under 5 minutes. The bad thing is that in reality, all of these organs are deformable, and all of these organs move from time point to time point. And in order to restrict patient motion, you have to ask them to hold their breath, which is less than ideal. So some of the major challenges that would need to be addressed, one is to account for the deformation of the organ, two is to robustly account for patient motion, and three would be, and which I think is the bottleneck in this current step, is developing automated methods for segmenting out the organs so that volumes can actually be quickly reconstructed. Sorry, there's one more question that came in. Do you have a recommended paper summarizing your work? Yes, it actually just got published. I can share it out. I can share it out through the link. So, yeah.
Very good. Thank you, Alex, for that. And again, it's in the physical and the virtual clapping. Thank you for your great work, and can look forward to your continued impact in ultrasound and care delivery. Yep. And I think there are some exciting opportunities to get this out into the world, and some both liver applications, but also other.
Sorry, I just also, before I sign up, I wanted to say a lot of this work I did not do alone. Thank you to all the members of Brian's lab. They were amazing and very helpful. So it's not just me. If you guys are going to look for relevant work, please, there are a lot of other cool stuff happening in labs. So it's, yeah.
I was just going to say to Alex, if you share that paper with me, when I post this to our MechE Alliance YouTube channel, I can actually link to the relevant articles there as well. So that's a good resource for anyone who would like to know more.
Sure. Yeah, definitely.
Perfect. That's great, Teresa. Thank you. So with that, Alex, again, thank you very much. And before you sign off, Teresa, if you can bring up our closing slides. As you know, this is a way to continue to engage with you, our faculty, our students, and our external partners under this new normal that we find ourselves. And our next MechE Alliance speaker will be next Wednesday, and we'll be having an external partner, but an alum, Dr. Albert Musa, who is a leader, founder of his company. We'll be talking about what Blaze Tech is doing to perform R&D in safety science, and bringing science and engineering to safety, which is certainly a topic that we're all very interested in general, but also in the COVID era. But he'll be sharing both a little bit about his career, how he came to do what he's doing now, and what Blaze Tech is doing. So that'll be next week, same time, same channel, 12 noon on Wednesday, July 1st. With that, I guess we have one more step. There is a mailing list, so please let us know if you have a recommendation for an external speaker or an internal speaker, and that can include yourself. And we try to have speakers from MIT students, MIT faculty, heavily biasing towards mechanical engineering, but also more broadly as well, and then our external partners. So please do reach out, and also get on the mailing list. You can hear about the other things that we're doing. And so with that, I wish everybody a good day. Stay safe. Alex, thank you again. And
Thank you.
everybody, see you next week.
Thank you, everyone. Have a great day.